Hi there, my name is Leonard and today I'll be discussing some of the key steps involved in a drug-facilitated intubation. A drug-facilitated intubation is indicated in a variety of circumstances. This can vary between ambulance services. However, in general, most indications aim to either maintain a patent airway, manage breathing, or take over control of various physiological parameters. Contraindications can also vary between services and guidelines. However, two very important contraindications for any intubation involving drugs include situations where the difficult airway guideline cannot be undertaken or where there is no functional electronic capnograph. When it comes to briefing the crew, it is important to do it early and with clarity. Everyone on scene should understand the decisions surrounding a drug-facilitated intubation, including why is the patient going to be intubated, where are they going to be intubated, how are they going to be intubated, and who is going to be performing the intubation and other roles. The actual delegation of roles can depend on a variety of factors, including the number of paramedics available and their clinical rank. However, in general, if you are the intensive care paramedic performing the intubation, then your ICP colleague will be your airway assistant. One ALS paramedic will be tasked with administering drugs, while the other scribes and verbalizes what is on the monitor. Nevertheless, regardless of who is doing what, it is crucial that each paramedic fully understands what is expected of them. This can be achieved by using explicit language and by asking each paramedic to repeat their role back to you. Within the literature, this form of communication is referred to as closed-loop communication and has been shown to increase efficiency and reduce errors in a variety of clinical settings. Whoever is in charge of intubating the patient also needs to ensure that an airway plan is formulated and verbalized to everyone on scene. An airway plan should consider various factors including patient presentation, practitioner skill set, as well as any potentially challenging patient characteristics identified during the pre-intubation airway assessment. Equipment selection can then be tailored to best match these factors. Put simply, it's all about using the right tools for the right job. An overall airway plan should consist of a series of 4 individual subplans. Plan A is aimed at maximizing first pass success, which, in a patient with normal anatomy, may simply involve using direct laryngoscopy with a standard Macintosh blade. However, in a patient with difficult airway anatomy, it may require going straight to video laryngoscopy with or without a hyperangulated blade. Plan B will often involve switching to a different laryngoscope blade, whether that is a different size or shape blade or video laryngoscope. It may also involve the use of bougies or stylets if not already utilized. In any case, it is about ensuring that the second attempt can achieve a better grade view and overcome the problems that were encountered on the initial attempt. In the unfortunate situation where 2 unsuccessful intubation attempts occur, Plan C aims to bring the patient back to a pre-induction state using a BVM and either an OPA, NPA or supraglottic airway device. In the event that is not possible and is deemed a can't intubate, can't ventilate situation, Plan D will be activated and a surgical airway performed. It is important to remember that regardless of whether an intubation occurs on the floor, stretcher or back of the ambulance, the setup should cater for the airway plan. What I mean by this is that all equipment in the airway plan must be made immediately available and laid out in a logical manner, usually in the order in which they appear in the plan itself. This means that as you work through each stage of the plan, equipment can be easily located. Once sedation plus or minus paralysis has been administered, it is time to perform laryngoscopy. Laryngoscopy is a technique used to visualize the glottis and is indicated in the following circumstances: inserting an endotracheal tube and removing a foreign body. It is contraindicated when there is suspected or known epiglottitis. Laryngoscopy technique can vary depending on the type of laryngoscope and blade selected. For this demonstration, I'll be performing direct laryngoscopy using a Macintosh blade. To start off with, ensure the patient's position is optimized for laryngoscopy. Placing the patient into the sniffing position improves laryngeal view by bringing the oral, pharyngeal and laryngeal axes into closer alignment. If possible, raise the patient off the floor until they are level with your mid-abdomen. Evidence also suggests that placing the patient in an inclined position leads to a better grade view and first pass success. Don't stand too hunched over and too close to the patient, but rather slightly behind them. Remember, you're trying to create a direct line of sight from your eyes to their glottis. With effective positioning of yourself and the patient, only a small amount of tissue displacement with the laryngoscope will be needed to bring the cords into view. Next, it's time to open the mouth with your right hand by placing your thumb on the lower jaw and your middle finger on the upper jaw. Pulling towards you also maintains the head in a position of extension. Pick the laryngoscope up with your left hand. Some anesthetists recommend gently gripping the lower portion of the handle to allow greater control of the blade. With the mouth still held open, insert the blade down the right side of the mouth. As you continue to advance the blade, sweep the tongue to the left and out of the way. Slowly keep advancing the blade while calling out landmarks until you see the epiglottis. The next important step is to position the tip of the blade in the vallecula. Upon achieving this, you can begin to lift your left arm. To do this, keep your left arm rigid and your elbow tucked in, as this will maximize mechanical strength. Lift forward and upwards along the line of the handle to indirectly elevate the epiglottis and expose the glottis. The first glottic structures seen are the posterior cartilages, namely the arytenoids. Next, you'll see the vocal cords and glottic opening. The epiglottis and posterior cartilages are the two most important landmarks, as they indicate the upper and lower boundaries of the glottic opening. If you see both of these, you know you have a grade 1 or 2 view and can aim straight through the middle. With the glottis now visible, verbalize your grade of view and then insert the endotracheal tube. In this demonstration, we're using a tube preformed with a stylet. It's straight to the cuff with a 35-degree bend at the end. Grasp the tube with your right hand and pass it into the mouth on the right hand side. It should be held on a significant angle initially to avoid obstructing the view of the vocal cords too early. Pass the tube through the cords and stop advancing when the vocal cords sit between the two black lines on the tube, which are the Australian standard markings. Remove the laryngoscope and maintain a firm grip on the tube. This is also a good time to verbalize length at lips. While holding the tube in its position, ask an assistant to pull the stylet out and inflate the cuff. Ask your assistant to then begin ventilating to confirm a tracheal waveform. Once confirmed, you can secure it with a tube tie. The process of laryngoscopy that I've just demonstrated may be all that is required to visualize the glottis in many patients. However, in patients with difficult airway anatomy, obtaining a good view of the glottis will require implementing additional techniques, such as pulling the upper lips back, removing any dentures, and performing external laryngeal manipulation. When it comes to laryngeal manipulation, 3 methods are available. Number 1 is burp, which involves grasping the thyroid cartilage and applying backwards, upwards, and rightwards pressure. Number 2 is cricoid pressure, which is traditionally used to prevent passive regurgitation. Despite some evidence suggesting it can also improve laryngeal view, its use remains controversial. And number 3 is by manual laryngoscopy. The modified version involves an assistant placing the hand on the patient's thyroid cartilage. The intubator then guides the assistant's hand until the best view is achieved. Evidence demonstrates that bimanual laryngoscopy is the most effective method at improving laryngeal view. Once the endotracheal tube has been inserted, it is crucial to confirm that it is actually sitting in the trachea. The gold standard, and really the only thing that you can rely on, is continuous waveform capnography. Waveform capnography has continuously proven to be the most accurate test to confirm tracheal placement, with studies demonstrating 100% specificity and sensitivity even when intubating cadavers. To confirm correct placement with electronic capnography, provide at least 6 ventilations and observe the monitor for tracheal waveform. If you see a waveform like this, you can be fairly certain you have placed the ETT correctly. Nevertheless, it is still important to look for other supplemental cues of tracheal placement. As you continue to ventilate, you should see adequate rise and fall of the chest. This is also a good time to perform auscultation. When listening to the chest, unequal air entry can be a sign that the ETT is too deep, most often down the right main bronchus. When listening to the epigastrium, bubbling sounds and an enlarging abdomen can indicate esophageal intubation. As ventilation continues, tube misting, improved patient color, increasing SpO2 and bag move in the spontaneously ventilating patient may also be observed. Once tracheal intubation has been confirmed, it's time to turn our attention to post-intubation care. In the first instance, a naso or orogastric tube should be inserted to aspirate gastric contents and decompress the stomach. At around the same time, post-intubation sedation should be provided. For the patient, having a piece of plastic rammed down their throat to deliver an unnatural form of ventilation is both physically and psychologically uncomfortable. Therefore, a combination of a sedative, such as midazolam, and an analgesic, such as morphine or fentanyl, should be administered. Depending on the post-intubation blood pressure, it may be appropriate to provide an initial bolus of medications to ensure good therapeutic levels of sedation before setting an infusion rate. Perfusion will also likely need to be managed. In addition to the patient's underlying clinical problem, hypotension can occur through a combination of drug-induced vasodilation and increased intrathoracic pressure due to positive pressure ventilation. Although the exact perfusion management strategy will depend on the patient's condition, a bag of fluid as well as an adrenaline infusion should be prepared for most patients. A reduction in sedation may need to be considered as a last resort. Gastric tube, sedation, and perfusion management are common to all drug-facilitated intubations. However, as intensive care paramedics, we must also consider 2 additional management strategies based on the patient's clinical presentation and underlying pathophysiology. The first decision is whether to administer long-term paralytics. Some situations that require post-intubation paralysis include traumatic, and non-traumatic brain injury in order to reduce the devastating effects that gagging has on intracranial pressure. In contrast, it is relatively contraindicated in the seizing patient in order to monitor further seizure activity. The second decision to make is whether to ventilate the patient manually or place them onto a mechanical ventilator. Mechanical ventilation does have many advantages in the pre-hospital setting, including maintaining consistent ventilation and eliminating BVM fatigue. For the majority of patients who are paralysed, mechanical ventilation is a smart option. In AV, we use the Medumat Standard A mechanical ventilator, which is a relatively basic machine. Once the patient is connected to the ventilator, it's as simple as selecting a minute volume and respiratory rate, and the total volume will automatically be calculated. However, it does have limitations, as the Medumat can only provide volume-controlled ventilation with a fixed inspiratory to expiratory ratio of 1 to 1.67. This makes it unsuitable for bronchospastic diseases such as asthma, which require a prolonged expiratory phase. Thanks for watching.